Luego de estas indicaciones generales, daremos inicio a nuestro primer panel, modelos de atención con redes integrales e integradas, panel para el cual hemos seleccionado experiencias de Canadá, Brasil y España. Para conocer la experiencia del Sistema de Salud de Canadá, nos acompaña de manera presencial Gregory Marchildon, profesor emérito del Instituto de Políticas en Salud de la Universidad de Toronto. Luego, de manera virtual, nos acompañará Adriano Masuda, profesor del Centro de Estudios en Planeación y Gestión de la Salud de la Universidad de Tulio Vargas de Brasil, quien nos compartirá su presentación sobre proceso, avances y desafíos del Sistema Único de Salud. Este primer segmento lo completará José Olmos, de la Escuela Andaluza de Salud Pública, quien nos compartirá su presentación sobre los desafíos de la construcción de un sistema de salud basados en APS y redes integrales e integradas de salud en España. Para esa primera parte del panel, el análisis y reflexiones en el contexto colombiano estará a cargo del doctor Luis Alberto Martínez Saldarriaga, viceministro de Protección Social, así como de la doctora Livia Forero, directora de Prestación de Servicios de MinSalud. Le damos la bienvenida a nuestros panelistas con un caluroso aplauso.
Mil gracias por la invitación. I'm going to present in English. I apologize, my Spanish is not quite good enough to present in Spanish. Gracias. Sí. ¿Mejor? Sí. Ok, mucho mejor. Okay, gracias. Ok. Yo comenzar con la presentación. I'm going to talk a little bit about the screen isn't on in front. I can't see the screen in front of me. So I'm going to have to look at the screen, I'm afraid. But what I would like to do is I would like to go through just a little bit of history in terms of the values and the principles behind the Canadian health system. I'm going to then talk about its organization. I will then talk about ongoing challenges in terms of integration and primary care. And then I will look at some outcomes in terms of the system, looking at some data to see the outcomes. So let me start with the origins of universal health coverage in Canada. And the first point that I would like to make is that it really began out of a very serious economic depression of the 1930s and the realization that most people did not have access, could not have access to health care, and that the system was broken in terms of the economic system, and that propelled a more radical political approach and the emergence of new parties, political parties, that were opposed to the status quo and began to make changes. Because Canada is a federation, this was able to begin actually in one of the provinces or states within the federation, which introduced very early a universal hospital coverage program actually in 1947. And the idea then spread from that one region or province to other provinces over time, and I'll go through that a bit. The next thing is to look at the principles, and perhaps if I could take this, can I take this out? Okay. I'm going to take this out, and I'm going to stand over here because I can't see the screen, if that's all right. The rise of alternatives meant that this one government that created universal health coverage was a social democratic government that was committed to major change, had put it in the platform, and then because of the nature of the decentralized federation, was allowed to basically do this, it be replicated, and then the federal government introduced cost changes that encouraged other provinces to adopt the same changes over time. So it turned out to be a very long process. The principles of the original design was compulsory registration so that it would cover 100% of the population. Single payer financing in the sense of it came from taxation and premiums, but no cost at the point of service. So basically a tax-based system. And the next important principle was that it was single tier. There was hospital ownership of all types at this time, but what the principle said was that you had access to any hospital, whatever its ownership, for service. And this created something which we call single tier coverage, a very strong form of universality. And then that translated through the rest of the country. The promise that was made was that there would be adequate remuneration to the hospitals and the doctors that worked in the hospitals, that this was only a first step. It only covered hospital diagnostic and inpatient drugs, but over time, other services would be covered as part of this package. They could only afford so much at the beginning, but the idea was that it would grow incrementally over time. There was a competitor to this. In fact, another province created another plan with very different principles. And what I have here is a table that explains these differences, and they're important because this debate occurs in every country in terms of the design principles, and it's very current. It's a debate which continues to this day in the United States, for example, which has a system which looks like the Alberta plan, which is described at the far right-hand side. The first thing is, the difference with the other plan was that it was voluntary enrollment with public subsidies to purchase private insurance. That did not cover 100% of the population. The second aspect was that, in fact, private insurance carriers would continue to be the dominant player rather than state financing, as in the Saskatchewan plan. The third difference was there would be access to multiple types of coverage, unlike Saskatchewan, where there was a single type of coverage, a single plan. And finally, user fees, whereas in the Saskatchewan plan, there were no user fees. These two plans competed, and ultimately the federal government had to choose between the design principles of each, and it ended up going with the Saskatchewan plan mainly because it covered 100% of the population and it wanted to invest in a program that would make a difference. And second of all, it was much less expensive, taking the insurance carriers and all of the overhead costs that were associated with insurance companies. And this is how we moved to a national system. The first intervention was in 1957 when the federal government set national standards for 50% financing based upon that original Saskatchewan plan. Coverage was on uniform terms and conditions, one package of coverage. Second of all, there had to be portability across the country, and there had to be public administration in the sense that it had to be answerable through the democratic system. And then in the 1960s, medical care, that is all physician and primary care services, came within that envelope. The dispute over design occurred again in the 1960s, but that was settled by the Government of Canada, again, partly on the principles and the values, but partly on pragmatism in the sense that it just seemed that the single payer plan was less expensive and covered much more of the population. So we have in Canada something called the Canada Health Act, which sets out the requirements for all of these provincial plans. And the first is public administration. It has to be operated on a nonprofit making basis by a public authority. The second is comprehensiveness. It has to cover all universal healthcare services that is medically necessary services without any major exclusions. The third is universality, and here's the key condition. It has to ensure entitlement to universal health coverage on uniform terms and conditions. There can be no differences. Portability, I've already mentioned. Accessibility simply means that there can't be user fees. And if a province allows user fees, either in terms of physician extra billing or hospital or health facility user charges, there is a deduction from the transfer of the central government to the provincial governments of that amount. It can't prohibit directly, but it basically uses the financial disincentive to prevent that. This is what the system looks like in terms of the country as a whole. I've tried to describe this in a very simple way, but you have the Canada Health Act, which acts as the key legislation, but a lot occurs through these federal, provincial, territorial councils in Canada because of the decentralized nature of the country. This is a little bit different than the situation you face in Colombia, but it's important to note that even when you have a decentralized polity, it is possible to deal with these issues. Ultimately, the system delivers universal health coverage, but a lot of the heavy lifting in terms of organization of the services, et cetera, occurs at the provincial and territorial government level. There are 3 layers in the Canadian system. The first layer I've already talked about. We call it Medicare, that's universal health coverage. The funding is general taxation. You can see the administration and delivery is a little different than the other 2 layers, mixed layer and then the private layer. And it's important to think about this because universal health coverage is not so much a set point destination, but it's something that you're working towards. You can never include everything in universal health coverage. The idea is that you're slowly working towards trying to be as comprehensive as possible. So looking at the design features of universal health coverage, in Canada, it's deep in the sense that there are no user fees of any type, but it's fairly narrowly prescribed. It's funded by both orders of government through general taxation. I've already talked about the single payer and single tier nature of it, and that's important. In Canada, there are no private hospitals or private facilities that are not open to everyone. There are still some for-profit hospitals and for-profit facilities, but under our system, they basically have to take all universal health coverage patients. So there's no distinction like there is in some countries between public and private in that sense. There's the framework, of course, the Canada Health Act, but all of this is actually a major contrast with the United States, which is right next door. And there's a great deal of misunderstanding between the 2 countries because of the very different health systems that each has. The mixed public and private layer, those are those areas where it's not under universal health coverage, but because of the inequities over time, provincial governments have stepped in and introduced public programs, but they've been largely targeted, not universal programs. And that's in the area of prescription drug plans, which is a mixture of government plans and private employment plans. And then social care, that is nursing homes, home care, supportive community care. And here, the provincial governments have played an increasingly large role, and eventually over time that will likely become part of universal health coverage. There's recent efforts as well to try to bring prescription drugs, outpatient prescription drugs, into universal health coverage. And the federal government has promised that within the next 4 to 5 years, it will negotiate a deal with the provinces to have it brought in. The private layer is most dental care, But even here in dental care, the federal government has moved to try to target some coverage with the idea that it will build towards universal health coverage. Most vision care, of course, complementary and alternative medicines and services. And here you see a lot of out-of-pocket payment and private health insurance. So let me move on to ongoing challenge number one, which is primary care reform. This has been one of the most difficult areas in Canadian healthcare to get right. We recognize that high quality primary healthcare is actually the very core of any high performing health system. And it has been difficult to make it so in Canada, to make it the very center of the system. Hospitals tend to dominate if they're allowed to, and it's very difficult to make primary healthcare the center of a system. And this is a problem that's common to most countries, I would argue. Part of the problem is separate governance and payment for physicians. Another problem is the power and influence of hospitals, and then the attitudes of general, which sees hospitals often as the center, and it's very difficult to change those long ingrained habits. There are current experiments with a number of different primary care type organizations to provide 24-hour, 7-day-a-week type of care, and to ensure that everyone can go and see a primary care provider at any time and not have to go to the emergency department of a hospital. The second thing is to ensure that these primary health teams are multi-professional and multi-collaborative, so they're more than simply groups of doctors, that you have nurses, social workers, psychologists, and others that are part of these teams to provide more holistic care so that they get the best care possible, and often with a focus on prevention and health promotion. The next area is accountability, and that is to actually register the patients as part of these primary health care practices so that the primary care practices become responsible for them and their health over time. And second of all, and this is much more ambitious, but to basically help those patients navigate the system and be the central response point whenever they go to the hospital or they go to a nursing home or whatever. The information about their conditions is relayed back to the primary health team, which continues to provide the bulk of their everyday care. The second challenge is integration, and this was attacked in two very different ways in Canada. One was beginning in the mid-1990s. 9 provincial governments decided to set up governance structures and administration that was basically arm's length organizations set up by the provincial governments to manage all health sectors. And this worked to some extent, but to some extent it didn't work, particularly in regional health authorities where the leadership did not properly act to coordinate, and you ended up with these very strict silos or layers of services, replicating the problem in the sense of hospital service layer, primary care layer, etc., rather than trying to create coordination across the health continuum. The provincial governments were frustrated by this, and they thought, well, perhaps the only thing we can do is create a single organization out of these regional health authorities, and created these very centralized provincial health agencies. Some of them have done better than others in trying to create this coordination, but there's no guarantee that these organizations, even though they're constructed to, in fact, facilitate integration, will actually produce integration at the end of the day. It's all in the way in which they're internally organized and the quality of their leadership. There's still physician services within this complex remain very difficult. Physicians are private in Canada. They're not connected in a governance sense to these health organizations. They're paid separately by the provincial governments, and so they feel no ownership with respect to these structures. And this has been an ongoing problem, and there's been efforts to try to change the remuneration and governance. So I'll quickly end on this, and that's health system performance, and just talk a little bit about some of the outcomes in terms of these structures in Canada. And you can see that Canada's health spending as a share of its economy and life expectancy as well are higher than the OECD average. You can see Canada in terms of that orange line and the other countries that are listed here. And then in terms of per capita health spending, that's spending per person and life expectancy, you see largely the same result. It's at the higher end of the list. The social health insurance countries tend to be higher because they spend more per capita, because these kinds of social health insurance systems, as opposed to tax-based systems, are generally more expensive. Now, I want to bring your attention to something called the Healthcare Access and Quality Index. This has been worked on for years by an enormous group of investigators, and it's basically covering 32 conditions, and you use something called amenable mortality. You find a date, a year in which people should never, before that year of age, 65, let's say, they should not die from that condition if there was the proper health policy and service intervention. And then they figure out, well, what is the excess mortality here? And they do it over 32 conditions where these kinds of interventions would actually save lives. And here you see the results. And you can look at the index. The higher you are on the index from 0 to 100, the better your health system performance. And I've just used some examples of some countries. Some of the people speaking here today, some of the countries you're looking at are on this list, as well as some higher income countries like Canada with high performance. Now, basically, if you're anywhere ranked in the top 20, anywhere above, let's say 92 and above, you're doing reasonably well in terms of the Health Access Quality Index. But you do see some surprises here as well. You see, for example, the United Kingdom is in rank 23, and given the NHS, you would expect it to be higher. The other surprise is the United States, maybe, or maybe it's not a surprise. It's a bit lower down on this list in terms of the Health Access Quality Index, despite the amount of money spent, despite what are in parts of the system very high quality medical care. You can see where Colombia is here. I've highlighted it. And then you can see where countries that are lower down on the index, like Brazil and Ecuador, are. Now, looking at the impact of COVID. Now, I've used COVID deaths per million as of November 13th, 2022, so very recent. So looking at the entire pandemic period. We recognize that this is always determined by a host of factors, right? Demographic attributes, geography, some policy interventions, effectiveness of the health system. So universal health coverage and access to vaccinations in primary care is only a small part of the picture, but I think a significant one. And eventually, if you have people that are very sick, particularly in the early stages of the pandemic, the quality of your hospital care would have an impact, and your access to health services would have a real impact in terms of this. So you can see the numbers here, and Cuba is right at the top, probably because of a high quality public health interventions. But you can see the other countries, and are there any surprises here? Well, probably a few. One of them is the United Kingdom. Again, fairly low. Another is the United States, which is very low on this list. But basically, the United Kingdom, Chile, United States, Brazil are all in very close together in a category. And then you see Peru very low in this list. And so I think this reflects, and I look at Canada and I think it reflects the fact that there was a fairly good foundation in terms of access to services, integrated with a reasonable public health system. It wasn't to say there were not problems. Every country faced problems here. But that foundation allowed for there to be a lower death rate in terms of COVID than in some other countries. So that just gives you an idea and some data to think about in terms of what it means to have a higher quality health system and a system that has good values and principles in terms of access to health services. So just to end, I've tried to emphasize the importance of design values in determining the features of the system. And so you have principles and values, you then have your design based upon that, and then you have to properly manage and lead the system. And it's never static. It's never going to be a perfect system. You have to keep managing it very carefully, and you have to keep adding over time. You can't, in a sense, expect that what you have is going to last forever. You have to keep working at it very hard. So it's a constant struggle. It's also important to recognize that as expensive as universal health coverage is, the services outside universal health coverage are often even more expensive, but they're paid for in various different ways, and the cost seems largely invisible, but it's very high because the administrative apparatus for that is very complex. It's not joined up, and as a consequence, very expensive. There are ongoing challenges in terms of primary care and integration, as I've said, in Canada, and a lot of, in terms of depends in terms of the future of the system on getting some of these things right, and that goes beyond the values. The final thing I'll say is that clearly, with a very strong foundation, however, you can have very positive changes in terms of access and outcomes. And you can then see those results in something like the Health Access and Quality Index in years to come. So I want to thank you very much, and I would be very happy to answer any questions in the panel discussion after. Thank you.